Thank you everyone for joining us this morning, and in particular, thank you to our two guest speakers. Really exciting. I'm really excited to hear what they have to say. I'll start by just a very brief introduction, and then I think each of you is going to talk for around about 15 minutes, and after that we'll move into a Q&A session. So Zoe Kourtzi is Professor of Cognitive Computational Neuroscience and has joined the Turing from Cambridge University. She is developing predictive models based on machine learning approaches to create individualized profiles of health across people's lifespan. The work enables early diagnosis of decline and disease and its use in clinical practice. She's going to talk to us today about how this diagnosis ability can help to support those with neurodegenerative disease, such as dementia, to receive the proper kind of treatment in the case of comorbidity with mood disorders. And Dr. Andy Blackwell is Group Chief Scientist and Strategy Officer at Ieso Digital Health, company offering an online cognitive behavioral therapy services together with the NHS, using artificial intelligence to support treatment by providing therapists with data-led insights about patients. And his principal role is to develop and implement a global science and technology strategy to support the commercial vision for the company. And he's going to talk to us today about how those models can enable more effective treatment, and also we'll discuss the ethical considerations of the approaches being used. So particularly appropriate topics for this week that we launch. Thank you both for giving up your time to speak to us. Zoe, I think, are you going first?
Yeah, that's right.
Yep.
Yeah.
Perfect. So we'll hand over the floor to you, Zoe. Thank you.
Great. Thank you so much, Ray, for the kind introduction, and thank you for inviting me. It's a great pleasure to be able to tell you a little bit about our work and also hear your feedback and questions you might have. Now, let me just share slides. Okay, let's see.
While you're sharing, Zoe, I'll just also mention to people that this talk forms part of our strategic partnership activities with the Alan Turing Institute, which we renewed our commitment to the Turing and began, in fact, a larger strategic partnership at the beginning of our financial year, so back in September. And thanks to that, we are able to gain access to speakers such as Zoe and many other engagement opportunities. So if people are interested in finding out more about our partnership with the Alan Turing Institute, I will pop the address, our internal address, into the chat window so that you can take a look there and find out more.
Great, thank you, Ray. So today I want to tell you a little bit about how we can use AI and machine learning in generating innovative solutions for precision diagnosis in mental health. And as Ray introduced, the main area that I have been working with is neurodegenerative disease, and particularly dementia. So if we could go on to the next slide, this really highlights the large societal problem that we have in neurodegenerative disease. Currently, globally, 50 million people suffer with dementia, and the cost only in the UK is already amounts to 26 billion. So a large, really societal problem, problem for health economies. So if we could go on to the next slide. So why is this a difficult problem? Why is the diagnosis a difficult problem? One is based on the measures and the data that we can collect this day at the clinic. We have a quite large percentage of misdiagnosis of patients. So typically what will happen is an individual that starts realizing that they have some memory loss, some problems with their memory, they'll go to the GP. The GP will run some scales. If the scores in these scales are looking rather low, then the GP will refer the individual to a memory clinic for further testing. Now, at this stage, the misdiagnosis of individuals who might have other comorbidities rather than dementia is currently about 20%. That's really a quite high proportion, given that individuals that might not have dementia can actually be treated for other comorbidities. For example, somebody with cardiovascular disease, they could be put on a very different diagnostic and treatment pathway, or individuals that might be suffering from mood-related disorders like anxiety or depression could be more precisely diagnosed. Now, all of these individuals that might have comorbidities may have exactly the same cognitive symptoms, may all be suffering from memory loss, from difficulties in concentrating, in making decisions, in multitasking, but it's very difficult at this point early on to stratify patients with precision and identify patients that might have dementia pathology compared to patients that might have other mood-related disorders. Now, for individuals that suffer from mood-related disorders, as Andy will tell us, there are actually treatments that can help, while we know that with dementia at this point, we do not have disease-modifying treatments. So a big challenge in terms of precise diagnosis. Another big challenge is the prognosis for neurodegenerative disease, and particularly for dementia. And that relates to the fact that when we talk about dementia, we talk about a group actually of disorders that have many different subtypes. And different subtypes have a very different prognosis and different survival times. So it could make a big difference if an individual is diagnosed correctly right from the beginning, early on, with the right subtype of neurodegenerative disease. This could make a huge difference for the patient and for their families in terms of planning the road ahead. So these are really big challenges where we feel that AI can help. And Emily, if we could have the next slide. This really shows us what we really need from new computational approaches, which is to be able to build transparent and interoperable algorithms for early precision diagnosis, for precise stratification of patients from low-cost and non-invasive data. And this could make a big difference for the diagnostic pathway, for personalized diagnosis and prognosis, but also for interventions and treatments, and can also make a big difference in the cost effectiveness of clinical trials and the drug discovery in the future. So if I can have the next slide, please. Thank you. So when we look in machine learning and we look into mining large-scale data to try and understand early diagnosis of neurodegenerative disease, we've got quite a few challenges to address. One is the heterogeneity. No patient is the same as another. The space is really complex. What might have caused the disease could be a lot of interactive factors that sometimes are measured with poor scales that are not sensitive enough, and a lot of data might be also missing. The data could be very sparse, could be incomplete. Also, another difficulty that we face is that the most reliable data are actually quite costly and quite invasive, the methods we have. So how can we detect neurodegenerative disease early when we can make a difference in the diagnostic and the treatment pathway from non-invasive measures that are cheaper for the NHS and for healthcare providers, but are also non-invasive and tolerable by individuals. So if I could have the next slide, please. Thank you. So focusing a little bit more on the problem of dementia, what you see here is that really dementia is a continuum from health all the way to disease. And very early on, we can identify and we can detect dementia by highly invasive measures, for example, lumbar punctures or radioactive PET scans. But actually what we want to be able to do is very early on detect dementia without having to collect this invasive data that is really not tolerable, increases people's anxiety. And we want to be able to make decisions of whether an individual will be healthy or whether they might be at the early stages of disease, but they will remain stable, they have a very slow progression, or whether they're progressing very fast, very rapidly, and they need immediate intervention. So these are the challenges we face. And in the next slides, I'd like to kind of run you through the approach that we are taking through research on how to tackle this. If I could have the next slide, please. Thank you. So the approach that we have taken in our work is to look at the least invasive data that we can have currently, and that's tests that test cognition and also MRI scans. And these are the more basic MRI scan one could collect. This is 5 minutes on the NHS, a structural scan. So we model this data to extract as precise and predictive features as possible. And then we run this data through machine learning algorithms that allow us to learn subspaces. These are metric learning classification algorithms. And from these algorithms, then we can build a trajectory modeling approach that allow us to look at individuals and see how they progress. If I could have the next slide, please, that shows you the models we built. We can build models on biological data. As you see on the left on your screen, this is biomarker data. It's gray matter from MRI scans, it's amyloid, is genetic data like APOE4, or we can build cognitive models by using measures of memory, of executive function, and of depression. And what you see is that both the more invasive biomarker data and the less invasive cognitive testing can actually give us quite high sensitivity and specificity in predicting a very kind of quite subtle change, which is separating patients that will either remain stable or progress. This is not just separating patients from healthy individuals, but making a fine discrimination about the progression that individuals will have. And if I could have the next slide, please, that shows you really that these two models, either based on biomarkers or on cognitive tests, can predict reliably the rate of cognitive change. And as you will see on the next slide, please, you can see that actually these models then allow us to take individuals that either have no dementia or at early stages, or are very early stages before any symptoms occur. And we can give the data to the trained model, and the model can tell us effectively whether these individuals will remain stable. Maybe they have nothing to worry about, and maybe their memory symptoms are because they are suffering from other disorders, for example, mood-related disorders, or they are progressing in terms of their dementia profile. And so either they are slowly progressing or rapidly progressing. And the way we do this is by the models tell us what is the healthy state, the stable state, and then how far each patient is from that state or how fast they are moving away from it. And if I could have the next slide, what you see here is that this really modeling based on AI methods can make a huge difference on clinical pathways. This is the current pathway that I briefly described in the beginning, where patients undergo when they first report problems with their cognition. And what you see is quite complex, but effectively different patients can go through different tests. But effectively, if you look at the end of that pathway, patients have to wait for about a year until they have a better understanding of potentially their diagnosis. Now, through this time, they could have gone through a lot of invasive testing, sometimes all the way to radioactive PET or lumbar punctures, to ensure that they have or do not have dementia, a pathway that creates a lot of anxiety. So if these individuals actually did not have dementia, but had mood-related disorders, it will only get worse for them because they have to go through very invasive and very anxious time period, and quite long time period, where they don't know what they have. They become really anxious because they know there are no disease-modifying treatments. This pathway, as you can see on the next slide, can actually be simplified and can become more efficient through these algorithms that mine lots of data. They are trained and tested on large cohort data, and when applied to clinical data, they can build a pathway that allows to determine whether an individual is stable, whether they are progressing slowly or fast. And as you could see on the next slide, this can have really an impact on how these patients are treated. Patients that are stable, they can be given reassurance. They do not have to be further having invasive diagnosis, or they can be sent to different diagnostic pathways, be seen at different by different clinicians. Patients that are slowly progressive can come back for appointments, but in the meantime, a lot of social care can be provided to them at home. Planning can start potentially at a slower scale. Patients that are rapidly progressive, actually, they need a more immediate treatment. But this means that quite a lot of patients are kept away from long-term hospitalization, are kept away from invasive and anxious procedures. So if I could have the next slide, please. So this is just summarizing. I hope that I've given you an idea of actually what we can do with machine learning and AI in terms of predicting diagnostic and prognostic trajectories with individuals, reducing the misdiagnostic risk, and generalizing our predictions as early as young individuals where they have no symptoms, potentially be able to integrate this in health checks, the way we check for cardiovascular health and try to prevent any risks. We can be checking for our mental health early in life and reducing the risk. And the next slide is the nearly final slide. I'd like to leave you with some quotes from our patients and carers that really show you how much people struggle. A really interesting quote from Robin Williams' wife that says, "How I wish we could have known why he was struggling." The anxiety that patients have to go through can really be reduced by using these modeling approaches. And the next slide summarizes a new or proposes a new initiative we are involved in with Alzheimer's Research UK. This initiative aims to actually move even to a less invasive and less costly space, the space of digital data, where we can combine data from mobile technologies, from our phones, from a Fitbit, with biological data to start building models that are robust, that in the future can be actually integrated in a health check that we can take in our 30s and 40s and be able to understand better what are the interactive factors that can actually mitigate risk for neurodegenerative disease. And I'd like to close with a final slide to thank you for joining in and thank all our collaborators, clinicians and computer scientists, engineers, neuroscientists. This takes anybody that can help. Thank our funders and my lab for putting all the hard work behind this research, and welcome your questions, thoughts and collaborations if you're interested. Thank you.
Thank you very much, Zoe.
Thank you for the slides.
Thank you.
Emily, should I go ahead and attempt?
Andy, thank you.
Let me just try, and you may have to be on standby. With let me just see. Firstly, thank you so much for sharing your time today, and particularly in Mental Health Awareness Week. So I'm going to talk about therapeutics for common mental health disorders, in particular depression and anxiety disorders. We're one of the largest providers of online mental health care. We operate principally in the UK, and we specialize in the use of computational methods to continuously improve the quality of care that is being delivered. But before we get into the computational methods and technology, I thought it might be worth just reflecting on the problem that we need the technology to help us with, first of all. And there are really some staggering statistics in mental health care. So, for example, right now, even in the most advanced mental health systems in the world, and we're lucky enough to have one here in the UK, we're currently treating around 20% of condition prevalence. Or said differently, 80% of people known to be living with depression or an anxiety disorder currently are unable to access treatment. of those people that are able to access treatment, around 50% will recover to wellness during the course of their care. So, so it's a coin toss whether or not you will get fully better during your treatment. And sadly, many people go on to experience a relapse or a reoccurrence of their condition in the months or years following discharge. So we've got some very significant challenges, and but perhaps thinking about that differently, opportunities to put technology to work in helping us to address them. So those are, I think, some staggering statistics. These conditions affect every family on Earth in one way or another. But the numbers don't ever really, for me, characterize what it's like to experience one of these conditions. So I thought, if you'll permit me, what I might do is just share with you a story that was recently shared with me by somebody actually I've known for quite a while. I didn't know that they'd experienced these challenges. But it really brought home to me what it's like to be in those moments when you realize you need to seek help. So this person said to me, told me this story. I hadn't ever thought of myself as someone who struggled with mental health. At around 30, poor mental health crept up on me slowly. My mind sometimes became full of thoughts angrily attacking each other, and my character too. These fight scenes in my head became common, triggered by normal things in daily life, and eventually they joined up through the day and the night into a continuous soundtrack of negative thoughts. Changes in my behavior started to appear. Occasional quirks became daily and nightly habits. I would drive to work and sit feeling breathless in the car outside for 10, 20 or 30 minutes. One day I just drove home again and I never made it in. Normal things caught me off guard and my head filled with noise. I genuinely didn't know that what I was experiencing was anxiety. I was still broadly functioning to the outside world, and the fire I felt on the inside was mostly invisible. But my life was in absolute tatters. I had no clue how to even begin to put my world back together, and eventually it became clear how unsustainable everything was, and I felt I was simply out of options. So we have these great challenges that most of our families are affected, that the treatments that are currently available are only accessible to a proportion of people, and those that are accessible work about half the time, and yet there's such a depth of human experience when people reach the point when they seek help. When somebody is in those moments, it's critically important that that we help them to make the best possible decisions about the care that they should receive. And one of my messages for this brief time together today is to think about AI in mental health slightly differently to, I think, how the field has been reflecting on it. So it's not about apps. We see lots and lots about apps, but really, I think it's time we think about AI in mental health as being an enabler of smarter decision making. So when somebody reaches out for help, they need to perhaps be reassured that that the capacity of clinicians in a network is being managed proactively such that they can receive timely access to treatment. We know that waiting for treatment makes it more difficult for someone to get well in the soonest possible time. A person in those moments should expect that their condition will be well characterized and properly understood, so they receive the right diagnosis, that they should expect to be directed to the right form of treatment. And in depression and anxiety disorders, that's typically a medicine or a talking therapy. And they should expect that decisions will be taken that will mean that they receive the right intensity or dose of treatment. Most often, people don't need to go to hospital for treatment, and it doesn't need to last years. And so we need to get people the right dose of intervention. And of the many hundreds or thousands of clinicians that might be available, particularly in distributed virtual care delivery networks, they might assume that a decision will be made to connect them with the best possible clinician for them that they're able to engage with. And of course, like every area of medicine, they should be assured that there will be some active ingredients in each treatment, that something is in the treatment that is known to be effective in helping to alleviate their symptoms. And if all of those things go well and the right decisions are made, they should enjoy an enduring benefit and then live their life in a way that's unhindered by mental illness. But unfortunately, more often than any of us would like, that isn't what people experience. And many people have very long and complex journeys of trial and error in finding the thing that works well for them. And I thought I'd just characterize that for a minute so we can understand our challenges. And my contention, I suppose, for these few minutes is that we may be able to use AI to learn from every person that is going through treatment and delivering treatment to help each person in that moment find the right path to recovery and to make the smartest possible decisions about the nature of the care that they should receive. So I'm going to give you two examples of how we might apply artificial intelligence in this context. And this rather colorful depression donut that you see on the screen in front of you is from a wonderful group of scientists called Odyssey. These are data from 264,000 patients showing the type of treatment. This is a drug treatment for depression that people receive on their first attempt, and the donut is a pie chart. So, for example, about 20% of people seeking help for depression will be offered citalopram, sertraline, and escitalopram, and other conditions. One thing to take from this is that an individual with essentially the same presentation could be offered any one of a range of different treatments, and they might work first time, but oftentimes people in this outer ring shows the second treatment people will take, and then another ring shows the third. People will often swap medications, they'll change dose, and it can take several months or years to find something that seems to be effective for you. It's very haphazard in the way people travel that journey. But as we start to accrue data at this type of scale, there suddenly becomes an opportunity potentially to say, for a given individual, given a particular treatment, here is the probability that they will respond to each of those different interventions. So can we machine learn the decisions that are made with regard to pharmacotherapy? I think we probably can. Similarly, it's even more complicated in psychological therapies, and there isn't a list that will stop in a moment, but it could be almost infinitely scrolling. There are so many different forms of talking therapy available, and it's almost impossible for any one individual, particularly in difficult times, to make informed choices between those different approaches. Now, in the UK, we have a highly structured system, but it's still difficult to know what might work best for you. Some of these treatments are highly effective, some of them are highly evidenced, but it's very, very difficult indeed to know, even as a mental health professional, which of these things might work best for a given individual. But again, there is in principle an opportunity to say, given a particular presentation need, given each of these interventions in enough people, which of those interventions has the most positive effect in getting that person well in the soonest possible time, and so that we can make decisions about what to recommend to people, not based on conjecture or based on the orientation of a particular therapist. They tend to choose a particular method, but based on the precise needs of an individual. So a data-driven approach to treatment selection. Now, historically, most of these decisions have been left to chance, and that's our reality. So where you end up in the system and what you receive isn't necessarily determined by data or by insight. And really, it's been very difficult to think about these problems because there have not been data sets available that could be used to train systems that could help us with that. What I think is incredibly exciting is that telehealthcare, the rapid adoption of telehealthcare, and in the last year, just to characterize this here in the UK, in January 2020, about 7% of talking therapies were delivered online. By August, about 94% of talking therapies were delivered online. That is not swinging back. People went there by necessity, but they're staying because it's more convenient. And this is likely to persist. So what that is in principle creating is an opportunity to study the clinical decisions and actions and outcomes associated with particular interventions. It's generating vast amounts of data from which we can learn what works and potentially provide insight to the clinician, to patients, and to health systems. And I think so. Right now, I think we are probably in the most important year in the history of mental health care, and part of that is because of this new way of people are accessing treatment. I will say that in a very specific way, artificial intelligence is enabling us now to address some problems that have been previously intractable. So one of the important things to note is that most of the treatment delivered in mental health care is talking between two individuals. Most information about your mental health and your response to treatment is encapsulated in the form of human language, and human language is really difficult to turn into numerical data, unlike genomics or the size of a bone fracture or blood chemistry. So we've been working very hard to use a TensorFlow-based system to codify and annotate utterances as they're exchanged between a clinician and a patient. And what you can see here in this colorful barcode is 1 hour of therapy, and we've analyzed about 400,000 hours of therapy this way now. And each little colored bar represents an utterance or a language event that is being exchanged between the clinician. So it's 60 minutes of time. You can see the first 8 minutes are spent with lots of green bars, and that's sort of chit chat. There's then about 25 minutes of pink bars, and this is where the system is detecting evidence-based structured therapy techniques, and then 14 minutes of sort of blended chit chat and therapy, followed by some administration and so on. So suddenly we can see into the ingredients of therapy, what's actually happening, what needs to happen in therapy. And then we've been working over several years to understand how the presence or absence and quantity and timing and sequence of these events, how that relates to clinical outcomes. So what is it that needs to be said and done in therapy in order to drive to help people get well? And where we are right now is to try and turn those insights into impact, and not by simply writing papers in peer-reviewed journals and getting them into a textbook and maybe a training curriculum, and maybe somebody remembers them and maybe they change their practice as a consequence, but actually to generate these insights almost in real time, or certainly in very fast cycles, and then to be able to give that guidance to clinicians in the moment so that they can make sure that they are delivering the active ingredients of treatment in every session. And here I've shown a prototype system in video that just helps people to monitor whether or not they're delivering the sort of basic hygiene factors of good therapy, and they're delivering some of those active ingredients. And there are all sorts of challenges maybe we'll discuss about agency and design and how people feel about being given structured guidance or perhaps even turn-by-turn guidance in the moment as to how best to treat patients with these satellite navigation style clinical decision support systems. So using a number of approaches such as this over the last few years, and these are some data from depression and generalized anxiety disorder captured in our service, and the percentages are recovery rates. These are objectively measured clinical outcomes that we report to the NHS. By accruing data, learning, updating clinical decision support and training systems, verifying that the changes that we make are in fact effective, and we've been able to push the recovery rates higher and higher each year, and really set against a backdrop of 30 years of complete stagnation in recovery rates in the field. So I think we've only really just begun. But I think there's a tremendous opportunity to use data in a much more helpful way, rather than just saying we will use maybe outcomes collection to audit care. We can use it to generate insight in very fast cycles. So I hope that perhaps you'll take from this and that. The opportunity for technology and advanced computational approaches isn't just about giving people access. More and more apps will not solve these problems. We have data being generated in the health system that can enable us to learn what works and to drive improvement in outcomes. COVID-19, one perhaps possible side effect of COVID-19 that may be positive is that it will radically increase data availability for these systems if we can learn to access those in a privacy maintaining and appropriate way, and that may lay the foundations for an explosive period of progress in mental health care over the coming years, which is exactly what we need. Just to say a little bit about Ieso, we're available free at the point of care in the NHS. So you can sign up and access the service often without even having to go to a GP. So if you or you know somebody that is needing help, you can look us up, and we are bringing these services to more and more people across the UK and beyond. So I said to Ray and Emily that if you guys are interested, perhaps later I can come back, and I surveyed our 850 clinicians to ask them what their top tips are for mental health for business people and high performers like you guys. And if you'd like, perhaps after we've had questions, I can come back and talk about some of those. So I'll stop there.
First of all, thank you both very much. That was fascinating. I also liked the sort of different perspectives, in a sense, of Zoe focusing more on the detection, and then Andy, we think a lot here at Accenture about the use of AI to support people and improve. There's this sort of fallacy of AI just replaces people, and we think that's utterly wrong. But actually, there's huge potential to use AI, to improve the way that humans do things, be it diagnose or all kinds of other things. And that was a fantastic example of yours, seeing those improvements in recovery rates based on the approaches that you took after stagnation. So that's really eye-opening. My question actually was going to go a bit in the app direction, though, if you'll forgive me, which was, there've been quite a few stories about in the press about companies developing systems that can spot signs of, for example, dementia through your use of a mobile phone and these kinds of interactions. Do you think that those sorts of approaches will become quite prevalent, and will we see and is it 5 years, is it 10 years, or what have you, a situation that's radically different from where we are today, and that our day-to-day interactions will be enough to give signs, but then clearly would need referral to an expert for more detailed diagnosis?
Would you like me to answer try and answer. Yeah,
you.
so I think these are all steps towards the right direction. Whether we are ready is not really clear. Whether the major challenge at this point is the validation. So as you say, we can get warning signs. If you start kind of responding slower to your phone, if your sleep patterns are not what they could be, these could all be signs that something is changing in our health, in our cognitive health. And this might be an onset of neurodegenerative disease, but it might be also, a really stressful time in life. It might be you got the flu. There might be many different factors. Doesn't mean necessarily that one has pathology. So the validation is really key, and it's what we call validation against gold standards, which is collecting enough data from mobile devices and technologies to be able to relate it, to build models that integrate this digital data with biomarker data. And then once these models are actually robust enough, then potentially we might not need the most invasive biomarkers, and we might be able to start making predictions that are precise enough and rely more on digital data. As far as I know, this is our challenge now. We have not achieved this, and the reason we have not achieved it is because it has taken us long to share data, long to be open about in science about all of the wealth of data we have. And obviously harmonizing data and bringing it onto the same platforms with algorithms is really important. And it's also about the people that we have. We don't have people that are trained in this kind of cross-disciplinary way. A computer scientist does not necessarily know the clinician's needs, and a clinician cannot do what the computer science can. So people coming from both biology and from both, AI need to really now work together and need to build the next generation that will be very much cross-disciplinary in terms of building these tools. But really, that's where we are going. If we want to also talk about prevention and not only about diagnosis at the stage where symptoms appear, it's really important to start building these tools that we can integrate into health checks. And I think this is definitely not that far. Our aim is within the next 5 years to be able to have seen breakthroughs with this, but we need to bring lots of people together, lots of data together. And we need
Fantastic.
to think outside the box.
Thank you.
Thank you. We've had a question from Oliver. Thank you, Oliver, for Zoe. You talked about transparency with regards to AI solutions for diagnosing these forms of dementia. One issue we've been seeing with the adoption of AI solutions is that they have somewhat of a black box nature, in that it's very difficult to understand how precisely a model arrives at a conclusion. This is not an issue with, for example, a clinician, because they can walk you through their decision process. Having the ability to analyse why a model has arrived at a categorisation will be essential to understanding how or why misdiagnoses occur. What are your thoughts on this, please?
Yeah, absolutely. Another really key challenge that has been identified and part of the validation of these AI-guided solutions. Really important, yeah. So it's critical that the models we have are transparent and we can interrogate them and understand these interactive factors that play a role in the decisions. And as these models get deeper and deeper and more complex, they have a lot of power to learn relationships that sometimes might be random. Just to give you an idea, when we look at samples, for example, across the world, they could be, simply the data might be coming from different brain scanners. And what the models are learning are the difference between scanner providers rather than the differences between brains. So we don't want this to happen, but there are methods now that are being developed in AI and machine learning to ensure that we do this transfer learning in a robust way. So we pull data across many different demographics because we want these also solutions to be transparent and to be equal. And we build data across countries where the way the data has been collected, it will be very different. And we interrogate really the model robustness and the transparency. Now, it's true that the clinicians are able to guide patients through their reasoning, but their reasoning is also, involves a lot taking many different factors, thousands of cases maybe that they have seen, and making inferences based on this. And they cannot always necessarily articulate this, but what they can say is based their immense experience, and looking at the data they have at their hands, they believe that with some certainty, a patient might be diagnosed with, one clinical label versus another. In a way, what we are proposing, as Andy was saying also, is that these systems, the AI tools, are decision support systems for the clinicians. They will not have the final word, and they're not there to replace the clinician. They're there to provide the clinician an extra source of knowledge, because these models, if we build them the right way, they would have learned from thousands of data sets, millions of data sets, across countries, across cultures, across demographics. And having only seen that data, if they're learning the right patterns, of course, then we'll be able to inform clinicians potentially with greater certainty, while start reducing the burden on the patients in terms of how many diagnostic tests they have to do, and hopefully informing also therapeutics in terms of, as Andy was saying, there are so many solutions that patients try, but without really being able to have a personalized pathway early enough before this has more of a cost on their mental health.
Thank you. Andy, I have a question for you. From the way that the kind of the cognitive behavioral therapy model has been produced, do you think that this will be able to adapt to kind of different cultural expectations or kind of language differences in a smooth and simple way?
So it's a very good question, and one of the things that we've been trying to understand using the system that's sort of decoding the language of therapy is, are there some common critical ingredients that are absolutely essential, regardless of the type of therapy that's being delivered? I apologize, my dogs feel strongly about this issue. I want to contribute. It seems and there do seem to be some critical ingredients that just need to be there. So it's almost like you can't, maybe if you don't even understand the full chemistry of how this sort of therapy pill is being formulated, you can look at and see whether certain ingredients are there. But it is a really important issue because, some of the things that we might look to, for example, if somebody doesn't leave the home for several months, or the use of words that describe our mental health, maybe essentially unrecognizably different between cultures. And really that speaks to making sure that we accrue enough data that's representative of those different sets of circumstances. What I actually believe, but cannot yet prove, is that we will find new forms of treatment, and maybe we will end up moving away from. I'm really sorry. Maybe we'll end up moving away from diagnosis as we currently think about it. So, for example, when we detect certain ingredients, there may be ingredients that are sort of that go across different therapies. So cognitive behavioral therapy, or brief interpersonal therapy, or mindfulness-based therapy, or and there are hundreds and hundreds of them. Maybe it's that there are molecules from each of those pills that can come together in a new form that is personalized for a given individual. The other thing I would say in when it comes to mental health conditions, less so now dementia, but actually most of the mood and anxiety disorders, they are rather phenomenologically defined. That is to say, a group of key opinion leaders sat around a table somewhere in 1994 and decided that you need 7 of 9 of these things, and then you would be given this symptom. And that's very useful for billing and for shorthand language between. So I can say to somebody, I think this person has depression, and they kind of get it, what they might be experiencing. So it's a use, but it does not predict clinical course in the absence of treatment, nor the relative likelihood of response to varying treatment options. So maybe it comes to one of your earlier points, but I think we might need to embrace complexity, and you know, sometimes it's so multivariate that full explainability may stand in the way of functional progress towards getting people the right treatment first time. And so I think that's we're right up against that right now, aren't we? We're learning that these more complex models probably will be functionally more useful to us, but we'll have to keep safety and you know, paramount in our minds as we take this kind of intervention to people.
What do you think the main barriers to people trying to engage with therapy, or potentially in the future, Zoe, getting that kind of digital information about them? So do you think that there's going to be some kind of pushback against that, or maybe people might feel concerned about it in a certain way?
Yeah, I think there's a lot in that kind of safety and trust that we need to build. People obviously feel very strongly about their data, personal data, and that we absolutely have to make sure that it is kept safe. But there's a lot in this space. And also it's really about raising awareness that what it means for a medical decision, both on the diagnostic and on the therapeutic side. But these algorithms are not replacing clinicians, but are providing a wealth of knowledge to the clinicians to guide them. And as Andy was just saying, we have to embrace complexity, and we have to raise awareness that just because something is complex, it doesn't mean it doesn't have usability. It's not functional. And these are complex diseases. They don't have a single cause. If there was a single cause, we would be able to find it, for example, in genetics. So we have advanced a lot in that biological sciences space. There's so much of interplay between lifestyle, between genetics, between immunology. There's such a complex space. So I think raising really awareness that these algorithms can be validated, can be robust, and can provide clinicians with support is really important, and also caring about the transparency and the safety. And this works, I think, for patients and their families, but also for medical staff or clinicians is really important for them to be engaged in this process. And so a lot of the work we do is actually with engaging both patients and carers and their families, but also clinicians to work with us, to tell us what their problems are, to tell us what the issues they find in their practices or in their everyday life. And we learn from that immensely in terms of guiding our work in developing these systems.
Thank you.
I was just going to add on to that. I think when people start to feel a sense of agency, and that they may be, I've heard somebody else describe it as being a co-pilot in their own condition, and we've seen in metabolic medicine, in diabetes, for example, and cardiovascular medicine, cerebrovascular medicine, stroke. Over the last few decades, people have started to understand at a population level that there are things that they can do to help and hinder their journey, their trajectory, and so you get an awareness that there are things in our biology and our environment that interact in a complex way to determine our path ahead. And I think as soon as we are able to, in a very tangible way, offer people alternate trajectories, to say, you know, actually there are things that that can affect the probability that you will develop dementia in later life. You probably need to get started quite early on in life in order for those to have a benefit. And I actually think it'll probably be the large technology companies that are able to offer us those alternate trajectories, because they're gathering the most data. And so I think it's about giving people, it's not just information, is it, about the response to treatment or the likely prognosis, but it's also somehow about giving them concrete ways in which they can affect their own trajectory. And then I think people will be much more receptive to that than they are to, because what is the deal is not quite there yet, is it? What do I get back in return for sharing these data with you? It's not as tangible as it might be.
Wonderful. It's very exciting stuff. Thank you so much, both of you, for coming and speaking with us today. It's been a really fascinating session.
Thank you.
Absolutely. Thank you.